In this presentation, we are going to show our experience at the State Oncology Center of the State of Sonora in the detection and management of changes due to toxicity secondary to pelvic radiotherapy. It should be mentioned that it is a topic to which little importance is given and that most oncologists overlook, largely because there is little knowledge and experience in its management. Its importance is not minor since the presence of cancer in women increases year after year. Thanks to advances in treatment, the number of women survivors is also increasing. But these women will be left with sequelae of the treatment that will affect their quality of life. Radiation therapy plays an important role in treating cancer in women. It will even be the main treatment in many cases. Radiotherapy produces adverse effects in different organs and systems, which will leave sequelae or toxicity of different degrees, and which will occur early or late, with temporary or definitive adverse effects. Of all these sequelae, the areas in which we can influence in our center are in toxicities or conditions at the genital and urinary level, where the patient will present changes in the tissues that will result in the appearance of tissue effects secondary to radiotherapy, such as atrophy, edema, ulceration, and mucositis, and toxic reparative changes, such as fibrosis, telangiectasias, adhesions, vaginal stricture, and shortening, and other more serious, but fortunately less frequent, such as fistulas. Damages for which there are multiple classifications, depending on the degree of affectation, such as the SETI scale or the URA-TEOG of 1982 and 1983, and the SOMA Lent of 1995. Classifications or gradations that are of little use in practice. I prefer to divide toxicities into two categories: those that affect function at the genitourinary level, and those that affect shape or anatomy. The purpose of this classification is to find treatment solutions to the effects of toxicities. Alterations that affect function. We divided them into two groups of patients. Patients who have a sexual life, and those who do not have or desire a sexual life. In these two groups of patients, the different toxic effects will have a consequence on the quality of life, an aspect that is generally little taken into account by the oncologist. On the other hand, conditions in shape or anatomy, which in general are vaginal shortening and stenosis, which will have an impact on the follow-up and control of patients after treatment, causing difficulty in the examination, which favors a late diagnosis of persistences and recurrences. Emphasizing that more important than the degree of toxicity individually, the effect that toxicities as a whole produce and have an impact on the quality of life and follow-up of these patients is more important. We will start with the alterations in function, which, as we have already said, will be sexual dysfunction, which is characterized by alteration in desire, arousal, lubrication, sensitivity, and orgasm, generally secondary to the pain caused by toxic changes in the vaginal epithelium. On the other hand, in women who do not have and do not want a sex life, there are the signs and symptoms of urogenital syndrome and or cystitis after radiotherapy, which will produce discomfort of dryness and genital burning with a tendency to vaginal infections. They present polyuria and nocturia, burning, bladder heaviness, and multiple treatments for symptoms similar to urinary tract infection. Discomforts that will alter your life with the impossibility of leading a normal social life and will affect your quality of life. How common is sexual dysfunction? Sexual dysfunction is relatively common in women of reproductive age, occurring in 15 to 40% of them. When menopause is reached, 50% will present it. In breast cancer patients, it will occur in 75% after treatment. And after pelvic radiotherapy, it will occur in 90%. We know that there are multiple reasons that cause sexual dysfunction. In order to decide how to treat it, we need to know its origin. In women of reproductive age, the causes of dysfunction are multiple. It is generally known that it is due to social, physical, or psychological causes and are divided into hypoactive sexual desire, anorgasmia, vaginismus, dyspareunia, and vulvodynia, each of them having specific treatments. In menopausal women, it is due to primary hypogonadism with estrogen deficiency. In women who have been treated for breast cancer, anti-estrogenic hormonal drugs will be added to primary or secondary hypogonadism. And in patients who underwent brachytherapy, tissue damage and damage to the estrogen receptors of radiotherapy will be added to primary or secondary hypogonadism. In patients who do not have and do not want a sex life, toxic damage will occur that will cause vaginal dryness, less lubrication, genital itching and burning when urinating. In addition to post-radiation cystitis, characterized by polyuria, nocturia, a feeling of pressure in the lower abdominal area, frequent or constant burning that can be confused with infection. And in late stage, it can initiate hematuria or urinary obstruction. All this affecting the quality of life. We will move on to talk about radiotherapy toxicities that affect the genital anatomy, alterations in shape. Although there is severe damage such as fistulas, fortunately they are rare and require specialized care. I would like to focus on the most frequent and important alterations, such as vaginal shortening and stenosis, since they not only produce alterations in function, affecting the couple's relationship, but also significantly affect the follow-up of the disease after treatment, limiting the physician's exploratory capacity and his ability to detect disease persistence and recurrence after treatment in a timely manner. And as an example, 80% of recurrences are detected after the recurrent disease gives obvious symptoms of its presence. Currently, it is intended to manage dysfunctions in shape or anatomy with the use of vaginal dilators, a method that aims to be preventive, but that is under discussion, since there are studies that are in favor and others against. 2 reviews of Cochrane, one from 2003 and the other from 2014, refer that there is no difference between using them and not using them. What is evident is that its use does not improve follow-up after treatment. We must not only see the effectiveness in its use, but also know what we are looking for with its use. What is its purpose? Is it intended that the dilators allow the patient to preserve a vagina permeable enough and of sufficient length to allow adequate sexual penetration? While sexologists tell us that vaginal sensitivity occurs in the initial 2 to 3 centimeters of the vagina, and that a vagina of 4 to 5 centimeters is enough for a woman to have a satisfactory sexual relationship. In 2013, at the State Oncology Center, we followed up patients after brachytherapy, where we performed monthly checkups with hysteroscopy, vaginoscopy, and blunt release of the vaginal adhesions present, trying to make the cervix visible to the examination. From a follow-up of approximately 20 patients, we found that 80% formed firm adhesions that prevented visualization of the cervix, becoming cloistered, and without being able to take cytological samples. Enclosure that occurred between 3 months and 20 months of follow-up, which explains why traditional methods of detecting cervical lesions such as cytology and colposcopy are not useful, and why 80% of recurrences are detected after obvious symptoms of disease persistence occur. Below, we will present 2 cases that show the importance of being able to explore the cervix in patients undergoing radiotherapy for cervical cancer. The first case is a 55-year-old patient sent for our evaluation 7 months after finishing chemotherapy, radio, and brachytherapy treatment for a 1B3 adenocarcinoma. Sent by having magnetic resonance imaging with the presence of polyp in the endocervical canal. The endoscope examination shows a vaginal fundus of 4 centimeters that ends in the bottom of the sac. Vaginal adhesions were released with blunt dissection, reaching the area of probable exocervix, where blunt dissection was performed with hysterometer, presenting the exit of serous collection material in the pericervical cavity. An endocervical canal with serous material leakage and the presence of necrotic nodulations on the upper side of the canal was observed. We performed hysteroscopy to look for any data of activity or pathology in the uterine cavity. A normal cavity with tubal ostium and atrophic endometrium was observed. The necrotic nodulations were reassessed without presenting data of lesion recurrence, and the necrotic tissue was eliminated if possible. And material was sent for pathological study that was reported as necrotic tissue and without activity data. It is assessed after 1 month finding a vagina of 10 centimeters and with a cloistered cervix. Adhesions are released and the cervix is reached, hyaluronic acid and vitamin E are added, which prevents new vaginal adhesions, and the following evaluations show vaginal bottoms of 12 centimeters and with visible cervical orifice and without activity. The second case is a 45-year-old patient with a year and a half of having received treatment with chemo, radio, and brachytherapy for stage 2A2 cervical squamous cancer. Follow-up with regular control studies and no data on persistence or recurrence. Sent for treatment for sexual dysfunction after pelvic radiotherapy. The existence of sexual dysfunction was confirmed, and as part of the study to initiate treatment, a hysteroscopic examination of the vagina and cervix was performed, with the application of acetic acid and Lugol in a manner similar to a colposcopy. Hysteroscopic colposcopy or endocolposcopy. A vaginal examination was carried out with a hysteroscope, and when the cervical orifice was reached, an organized clot was observed, which, when the examination was followed and after applying acetic acid, showed an epithelium with a glandular spongy appearance, which showed the appearance of abnormal vascularity. Biopsy is taken. The biopsy reports well-differentiated adenocarcinoma. These 2 cases show us the importance of preventing the confinement of the cervix in order to improve the follow-up of these patients and to be able to make timely diagnoses of persistence and recurrence. Currently, there is no method that can prevent the confinement of the cervix. This enclosure of the cervix has led to the fact that traditional methods of timely detection of cervical lesions cannot be used after treatment with pelvic radiotherapy, both because they hide the cervix and because they produce changes in cellularity that make it difficult to interpret. The exploratory methods include digital exploration and the interpretation of tomography, magnetic resonance, and PET scan images. This has increased costs and has caused that in many centers, they do not have the means to do a correct follow-up, in addition to not improving the possibility of making diagnoses of persistence and that the detection of recurrences is late. As shown by the reality that between 56 and 95% of recurrences are detected after the appearance of obvious symptoms of tumor activity, such as bleeding, abnormal discharge, or pain. It remains pending to find methods of prevention of vaginal toxicity and to allow simpler, cheaper, and safer methods to be used to detect persistence and recurrence. We will look at the management and prevention of these dysfunctions caused by radiotherapy toxicities. Alterations in function are currently managed with the same therapeutic methods used in the treatment of urogenital syndrome of menopause, without taking into account that the causes of its presence are different from those of menopausal women, so current therapeutic experiences show poor results. If we review current therapy, according to what is indicated by the medical groups, you should start with local treatments, which are lubricants and moisturizers. We have to clarify that these two groups of drugs have different functions and indications. The lubricant has the function of facilitating penetration, so it should be applied before each sexual intercourse. The patient who does not have a sex life does not require the use of lubricant. In women who have received radiation therapy, tissue damage will not allow its use to be of sufficient use because of secondary tissue damage, which is the cause of dyspareunia. It could facilitate the relationship in multiparous patients that radiotherapy did not produce a significant vaginal narrowing. It can be used together with moisturizer. The humectant has the function of moisturizing the vaginal vulvous environment. It should be used constantly, 2 to 3 times a week for it to have an effect, and will be very useful in the patient who does not have a sexual life to manage dryness, itching, and burning secondary to atrophy. It should also be clarified that the only moisturizer that has proven useful is hyaluronic acid, and vitamin E can be added. If there is no response with the use of lubricants and moisturizers, the use of estrogens is used. If there is no contraindication, local estrogens are preferred, or, if necessary, systemic estrogens. There is still controversy and difficulty for its use in patients with hormone-dependent cancers. There are also selective estrogen receptor modulators, which will have the same controversy. There are also a number of medications that will affect estrogen receptors or produce estrogen receptors indirectly within your metabolism, such as testosterone and DEA. Also referred to are drugs that act on desire and sensitivity, such as testosterone, DEA, flibanserin, and sildenafil, which, although they can act on desire and arousal, will have against dryness and pain during intercourse that, in the long run, as long as they are not corrected or treated, will again produce a decrease in desire and arousal. It is important to know that in addition to the tissue damage caused by radiotherapy, it also produces a decrease in the expression of sex steroid hormone receptors, so there will be a lower tissue response to hormonal treatments. The same will be seen in the tissue response to the stimuli of procedures that, based on the heat effect, aim to improve the tissue response and repair the damage caused by radiotherapy, such as laser or radiofrequency. The only treatment that has been established in large oncology hospitals, which is aimed at improving sexual dysfunction after radiotherapy, are multidisciplinary groups with psychological support and physiotherapy, which aim that, through relaxation, patients can restart a sexual life, methods that have improved, but with a modest response. These therapeutic responses are so poor and have caused new therapeutic paths to be sought, and therapeutic options have been sought in functional and regenerative medicine. Thinking about treating tissue damage. Searching the medical literature for results of new therapeutic procedures, we found the effects of fractional CO2 laser in the treatment of urogenital syndrome of menopause. Here we show 2 articles that show the response to the laser in menopausal women, where the measurement parameter is the FSFI index for sexual dysfunction and the VCHI index that corresponds to the vaginal health index, where the parameter of normality for sexual dysfunction would be an FSFI index greater than 26.6 and a vaginal health index greater than 15. The study showed an initial FSFI of 17. The index was increased to 25 and 24, obtaining a statistically significant increase, although the median was not greater than 26.6, which would be the parameter to determine that the patients left the classification of sexual dysfunction. Although it has not been achieved that patients leave the category of sexual dysfunction, surely this modest improvement must be a great achievement for a patient who cannot have a life as a couple. But we must also recognize that at least 60% of them did not manage to eliminate their sexual dysfunction. When laser treatment is applied to cancer patients, studies showed lower initial FS-FI indices than in menopausal patients, and also presented smaller increases after treatment, which is explained by the damage secondary to cancer treatment. We found only one study showing the effect of CO2 laser and using the FS-FI index in patients after pelvic radiotherapy, where it can be seen that the initial FS-FI index is lower than in previous studies, probably due to the damage to the genital epithelium by radiotherapy, also showing a very poor effect of laser therapy in these cases. Given these data, we searched the medical literature for any other procedure that could act on the repair and improvement of tissue function. And we found 3 articles with the application of platelet-rich plasma in patients with sexual dysfunction, where it is shown at the beginning, very similar rates to those of menopausal patients, and with very satisfactory achievements. Achieving a good response, and in one of them the median is achieved to exceed 26.6 and leave the classification of sexual dysfunction. Platelet-rich plasma has already been used in different medical areas, and its reparative and functional effects have been demonstrated. Given these data, in 2023, we carried out a prospective pilot study where platelet-rich plasma was applied to patients treated for cancer. Patients with more than 2 years of having concluded their cancer treatment, to whom platelet-rich plasma was applied with mesotherapy technique in the vagina and introitus, with 4 applications separated by a month to a month and a half between each one. Measurements were made in each session of the Vaginal Health Index, FS-FI Sexual Function Index, vaginal length measurement, and vaginal distension capacity with dilators. Article whose results were published in 2024. In this image, you can see how the 21 patients had a baseline median of 12.8 and 100% had sexual dysfunction. They presented an increase in the median after each treatment session, causing the median to leave the category of sexual dysfunction after the 3rd application. Starting with a median of 12.8 before treatment and achieving a final median of 29.7 that is outside the category of sexual dysfunction. If we analyze individually by patient, we find that only 4 patients were unable to get out of the sexual dysfunction parameter, although all of them presented a statistically significant improvement. Therefore, 80.1% of patients managed to get out of sexual dysfunction. All were patients with a history of treatment for cancer, 10 for cervical cancer, 5 for breast cancer, 4 for endometrial cancer, and 2 for rectal cancer. If we focus on only the patients who were subjected to brachytherapy, we will see that it is in this group of 14 patients where the 4 patients who did not manage to get out of the definition of sexual dysfunction are found. This increases the percentage of patients who did not manage to leave the sexual dysfunction category. In any case, 100% presented statistically significant improvement, and 70% left the sexual dysfunction category. This gives an excellent therapeutic response. If we pour these data into the bibliographic review table, we see that the results of the other therapeutic methods are far exceeded. Initial FSF indices were found to be similar to those of patients with a history of cancer and treated with CO2 laser, but with achievements after treatment much higher than the other methods, and with FSFI above 26.6. Analyzing each of the parameters of sexual dysfunction, we see that before starting treatment, the most affected areas were lubrication and pain, which are the areas that improve the most at term, and which improve the sexual response of desire, arousal, orgasm, and satisfaction. In the table of measurement parameters, it can be seen that the treatment did not modify the vaginal length, probably because the patients have at least 2 years of having finished their radiotherapy treatment. And it is shown that the increase in vaginal distension capacity length, probably because the patients have at least 2 years of having finished their radiotherapy treatment. And it is shown that the increase in vaginal distension capacity is important in the results and has a statistically significant increase. Below, we will show the impact of treatment on cystitis after radiotherapy. Post-radiotherapy cystitis is defined as early, when adverse effects occur within the first 3 months after radiotherapy, with the presence of symptoms that include frequency, bladder pain, increased number of urinations, day and night, dysuria, and urinary urgency. Post-delayed radiotherapy cystitis is when these adverse symptoms appear or persist after those first 3 months and can occur after several years, hematuria and urinary obstruction caused by clots. Currently, the management of this toxicity is based on analgesics, anti-inflammatories, and in extreme cases, surgery. There is frequently abuse with the indication of antibiotics. To date, there are poor results with these treatments. New treatments are sought in regenerative and functional medicine with stem cells and exosomes. The application of platelet-rich plasma for the treatment of toxic sequelae on sexual function also presented beneficial changes in post-radiotherapy cystitis. To assess bladder function, the female lower urinary tract symptomatology questionnaire was used as measurement parameters. ISIC-FLETS-LF, which assesses the symptom and its effect on quality of life, or degree of discomfort. It consists of 18 questions with their corresponding impact on quality of life, covering 4 areas of alteration. Alteration in frequency, in urinary urgency, in incontinence, and in bladder emptying. In this graph, we can see how the trend curve is downward, showing progressive improvement or decrease of the affected area after each application. The affected area was classified as severe when the score was between 15 and 20, moderate with a score of 9 to 14, and mild between 3 and 8. All these alterations correspond to changes of late toxicity, since all patients have at least 2 years of having finished their treatment. The areas with the most severe changes were incontinence with severe symptoms in 50% of the patients, and secondly, urinary urgency with 18% of severe symptoms and 31% of moderate symptoms, which gives 50% of moderate and severe symptoms. The least affected areas were the frequency with 37% of moderate to severe discomfort and emptying, which, although only 1 patient presented severe symptoms, was in a patient who, after 4 years of having finished brachytherapy, began with severe symptoms with bleeding and urinary obstruction due to clots, requiring multiple hospitalizations with catheter application and bladder lavages, showing an extraordinary improvement with a decrease in symptoms after the first application and disappearance of bleeding and evident improvement of the other symptoms with the second application. In the parameters of urgency and incontinence, at the beginning 18% of the patients were asymptomatic, and after the 4 treatments, more than 80% were asymptomatic, which shows the effectiveness of this treatment in the management of cystitis by radiotherapy. In conclusion, we can say that platelet-rich plasma is an excellent treatment for the management of radiotherapy toxicities, leaving as an option the incorporation of the CO2 laser as a complement, which would surely improve the results, although it would increase costs and the impossibility of applying it in institutional medicine, and as a long-term therapeutic complement to the local application of hyaluronic acid to preserve tissue changes. We still have to be able to prevent vaginal adhesions with confinement of the cervix, which together with the use of hysteroscope to be able to perform hysteroscopic colposcopies and improve the opportunity to diagnose persistences and recurrences that would surely improve the prognosis of these cases. With this, we end this presentation, in which we show the treatments that we currently provide at the State Oncology Center of the State of Sonora to improve the quality of life of women after cancer treatment. Thank you.